Well, thank you. Thank you very much for having me. I want to thank Professor Salins for inviting me to talk to you guys. So I work at the kids hospital, and I'm the spine guy, so I look after spinal problems with OI and other conditions. So I'm not going to talk a lot about or anything about the long bones, which is looked after by another group of my colleagues. So we'll try and concentrate on the spine. I'm sure a few of you from Sydney, if you're here, you've been to the kids hospital, and that's where I work. And we have a large team that look after kids with various bony dysplasias, and OI is one of those areas because we have a very big endocrine unit, was previously led by Professor Salins, and so we have a lot of OI patients, kids being treated for OI at the kids hospital, and when they get spinal problems, they do get referred to us to look after those problems. So this is by no means a comprehensive talk on spinal pathology, which is a broad overview, and I'm happy for anyone to put up their hand and stop me and ask questions. I think that might be better than trying to ask questions at the end. So just put up your hand and we'll stop and answer any questions as we go. So as you know, you guys know more about this than I do, but it's a type 1 collagen disease. Affects about 1 in 20,000 birds. I was just speaking to Professor Salins, and historically there were 2 genes identified. I believe now there are 17 or so different genomes, gene types identified, so we can't really catch up or keep up with all these changes. But when we teach our students, we talk about the COL1A1 and the COL1A2 genes that affects the alpha-1, alpha-2 fibers of the collagen network. And basically what it does, it increases bone fragility, and this is what causes most of the problems in the spine and in the long bones. This is the classification that Prof wrote. There is now 5, 6, and 7, but we mainly look at these 4 groups, which are the more common groups. So what are the common spinal pathologies? Scoliosis and kyphosis are probably the 2 commonest spinal deformities we see in OI, and they can either occur separately or they can occur together, as we call a kyphoscoliosis. This is a little kid with type 3 OI who's got a very severe spinal deformity. That's been a challenging problem in my last 3 or 4 years of looking after this kid. So this is an example of a kyphoscoliosis. So whilst they can occur independently, they can also occur together. Spondylolysis, meaning a fracture of the pars, we'll talk about a little bit more about it later on, is also fairly common and prevalent. And then when you have a spondylolysis, you can get a spondylolisthesis, where the 2 vertebrae slip because there's a disconnection at the back at the pars. And there are 2 types of spondylolisthesis, which is called isthmic and elliptic. And we'll talk about that as well in a second. Then, of course, you can get spinal fractures. And the spinal fractures, there can be microfractures happening all the time, which sometimes then causes deformation of the vertebrae. So they either look squashed or concave, or they can sometimes look wedged, and that's because of the ongoing process of microfractures. So that can most often sometimes be asymptomatic, so as most of these issues, and all it does is it deforms the spine because of the multiple fractures. Then the other important thing is, I was speaking to Andy today, the craniocervical abnormalities, basically 3 types. You can have basilar impression, you can have basilar invagination, which is the dents going through the foramen magnum, or you can have platybasia, which is flattening of the base of the skull. Those are the 3 common abnormalities in the craniocervical junction. So before you look at an abnormal spine, I think it's important to know what a normal spine is, because that's how you can differentiate what's abnormal from the normal. The spinal balance in a walking and standing patient is a composite between the spine, the pelvis, and the hips. They kind of link together. One thing can affect the other. So if you have a flexion contraction of your hip, that can antevert the pelvis and create a hyperlordosis because you want to stand up straight. If you have a loss of your lumbar lordosis and you get a flat back, then you can go forwards, which means your pelvis will tilt backwards to try and bring you straight. So all these things are interlinked. And if you have a thoracolumbar kyphosis, then you can have a lordosis above that and a lordosis below that, because The brain is always programmed for you to be standing straight, and it does all these compensatory mechanisms to make that happen. And of course, it can also be postural, where kids or sometimes young adults can stand in funny ways and get used to standing like that. So this first X-ray, you see I'll try and show you what I'm looking at. Sorry. Now we don't have a pointer here. Let's see whether I can bring my pointer. Okay, it doesn't work. So you have that's a normal thoracic kyphosis and a normal lordosis and a fairly normal pelvic orientation, whereas this film here, you see there's an increase in thoracic kyphosis, which means there will be an increase in the lumbar lordosis, which means when you look at you from the side, you have very prominent hips because you have increased lordosis. Now, this is not an OI person, but it's a normal spot. This is the Sherman's kyphosis, but this is what happens when you have an increase in the thoracic kyphosis. So we have looked at what is the normal alignment. Where should the lordosis be? Where should the kyphosis be? Where should the apex of these curves be? So this is, again, a normal curve. And by looking at a large group of normal patients, we have worked out that the majority of a lordosis or the lumbar curve should be between L4 and S1 in a spine that has a normal alignment. And between about T10 and L3, your spine should be fairly straight, or if not, about a degree of lordosis. So you shouldn't have this part of your spine bent forwards. Your kyphosis, which is the forward bend, should be at the top. And the apex of that is usually around T7. So if you know what the normal alignment is, then you can work out what's abnormal. Now, the pelvic incidence is something that has been looked at a lot in the last 10 years. And what that basically tells you is your pelvic orientation. And we'll have a look at a picture as to what that is. So the pelvic incidence is the relationship between your sacrum and the pelvis and hip. And that is a constant. Once you are skeletally mature, it's like your thumbprint. It remains the same throughout life, irrespective of your 3D orientation of your pelvis. The pelvic incidence is a constant. And your lumbar lordosis is built on your pelvic incidence. So someone with a high pelvic incidence would have an increased lumbar lordosis, because a high pelvic incidence means your pelvis is more tilted and you have to have a bigger lordosis in order to stand straight. Now, why is that important in OI and in any spine is that if you have a high pelvic incidence, there is also a high incidence of a L5 pars fracture or a spondylolysis. And that's because your shear forces are more vertical at the L5 pars, and we find that the spondylolysis is more common, even in the population with no OI, is more common or has a high prevalence in high pelvic incidence. So if you see a patient with a very high pelvic incidence, we'll look at the pars at L5 and make sure they don't have a stress fracture or even a spondylolysis already developed. And the pelvic incidence, again, so this slide shows that it doesn't change depending on your 3D orientation of your pelvis, because it turns around your hip joint. So the pelvic incidence is a constant. The pelvic incidence equals pelvic tilt and sacral slope. So someone with a high pelvic incidence would have a high sacral slope, and these two things are inversely proportionate. So if you have a high sacral slope, you'll have a lower pelvic tilt. And your normal pelvic tilt should be about under 20 degrees, which means that when you're standing up you can stand up without spending any energy, because your pelvis doesn't have to be retroverted by your gluteal muscles. So in a normal alignment, the pelvic tilt is about 20 degrees and the sacral slope forms the rest of the angle. And those two together would match your pelvic incidence. Any questions on that? All right, let's keep going. So what's scoliosis? Scoliosis is a structural lateral rotational curvature of the spine. So when you look at an X-ray, you only see a 2D picture, whereas scoliosis is actually a 3D deformity. When I explain this to my kids at kids hospital, I tell them it's like a corkscrew. So you're getting a picture of a corkscrew and only seeing a 2D picture, and you got to understand it's a 3D deformity, and that's why when you have scoliosis, one side of the ribs can be more prominent than the other, because your whole rib cage along with the spine is being rotated. But when you take an X-ray, you're looking at a 2D picture and you only see the lateral rotation. So you kind of underestimate the degree of deformity in terms of the twisting of the spine that patients do get. So we divide scoliosis into two main groups. Early onset is when the scoliosis comes on before 10 years, and late onset when it's after 10 years. And then we have four major groups in which we categorize these patients to: idiopathic, congenital, neuromuscular, and syndromic, and the OI comes into the syndromic category. And it's one of the commoner causes of early onset scoliosis. And when it happens in OI kids, it is relentless, it is severe, and it poses a lot of challenges in terms of management because of the fragile bone. The options we have to control the curve is very limited, and the complications of instrument-related failures are very, very high. So what's the cause of scoliosis? If you read about this, there are multiple theories, but the consensus is that there's ligamentous laxity causing instability because it's a collagen disease, and there's also collagen in the ligaments of the body. There is increased vertebral body fragility, which means there's microfractures that deform the vertebrae, and that can go into like a vicious cycle. So the rectangular vertebrae becomes like a trapezoidal shape, and that continues because the forces across the vertebrae changes, and you get more microfractures. So the vertebral body shape is a big thing in OI scoliosis. And of course, there's some degree of muscle weakness, and sometimes there can be leg length discrepancies due to your long bone fractures and malunions, which can cause a pelvic tilt, and that can give rise to a scoliosis. So it's multifactorial. There are multiple factors that go into someone developing a scoliosis. We have looked at the incidence of scoliosis. This study here looked at type 1, 3, and 4. Whilst it is a common cause of scoliosis, it can also cause late onset scoliosis. And the prevalence is obviously more with the more severe deformities, with the more severe OI. So type 1, there was a 39% prevalence of scoliosis, type 3, a 68%, and type 4, 54%. The type 1, which is the milder form of OI, the progression rate per year was obviously less, as you would expect. Type 3 was the highest, being the most severe form of OI, which is about 6 degrees a year, and type 4 was about 4 degrees. Now, this is important because if you look at adolescent idiopathic scoliosis, usually after skeletal maturity, the progression of the scoliosis is significantly reduced to about 0.5 to 1 degree a year. So when kids get to 15 and 16, we can be fairly sure that if they have a 30-degree curve, that's not going to become 60 degrees in 10 years. It at the most would add another 5 degrees. That's different in OI kids. The progression is relentless through life because of the bone fragility. It doesn't follow the normal idiopathic type progression that we see, which is very mild after skeletal maturity. So what are the clinical presentations of scoliosis? So, and this is important because you need to be, with the mild OI, you want to get screened on a regular basis to look at whether you're developing a scoliosis even in late teens or young adult life. So you can have a coronal decompensation where your trunk is shifted to one side. So when you get someone to stand, their head's not sitting over the pelvis. You can also get shoulder asymmetry, especially with the thoracic curves. One shoulder gets pushed up, so all you see with the clothes on is that your shoulders are not balanced. Why is one shoulder higher than the other? And that's because you've got a scoliosis. You can also have the posterior ribs become prominent because of the rotation of the spinal column. And then there can be flank asymmetry like this girl has, where one flank is dipped in more than the other. And of course, the pelvic tilt. When you put your hands over the pelvis, you can feel one pelvis higher than the other. That can also be caused by leg length discrepancy. You've got to be a bit careful as to what's causing the pelvic tilt, but more commonly than not, it might be the scoliosis causing the pelvic tilt. So the best test to do that, I'll show you a picture of it, is the Adams forward bending test. Who's heard of that? Very good. So bring your hands forward like this. So you bring your scapula right to the front, and you bend down and touch your toes, and get someone to look at your back from the back, and you see asymmetry of your chest wall straight away. Huh? Even in a mild curve that you sometimes don't see with you standing up straight, when you bend forwards, you can see the asymmetry, and that could be the earliest sign of a scoliosis. And of course, the leg length discrepancy. You can always check for the leg lengths. This is the Adams forward bending test. That's in a normal kid. and you see the asymmetry that you see on the rib, and that's because of the rotation of the rib cage. So we used to do this in schools some time ago, where when you're 11, 12, there'll be a bunch of nurses coming in, bending all the young girls down and having a look at that and picking up early scoliosis. We don't do that anymore. But in kids with OI, I think that should be mandatory to have a fairly regular check of the back with the Adams forward bending test by your primary care physician, your GP, just to make sure that you're not developing a scoliosis. So how do you measure Cobb angle? So this is what we talk about when you try to objectively measure how much the curve is. You basically pick the vertebrae that is tilted at the top and bottom, the most distal vertebrae, caudal and cephalad. You draw a line along the end plate, and then you draw another line perpendicular to that, and you'll get the angle which is called the Cobb angle. And it's a fairly universal way of objectively measuring the scoliosis curve. So if say you've got a Cobb angle of 60 degrees, we all know what that means, and we all know how it's been measured. So it's a universal way of measuring the severity of the scoliosis, and that's what we do every 4 or 6 months. When we see you and get an X-ray, we measure the Cobb angle.
Can I just ask?
Sure.
If you've got a double scoliosis,
Yes.
is there a double?
Yes, there are 2 Cobb angles. So you do the same thing on this curve, but it's a mirror image of that. So you draw another line here, and you do the same thing here. So you get so we generally keep an eye on the structural curve. So the bottom curve is a compensatory curve, but yes, you would always measure. In fact, typically you'd get 3 curves. One, you get the structural curve in the middle, and then you get the compensatory curve at the top and at the bottom. So you get an upper thoracic curve, middle thoracic curve, and a thoracolumbar curve. Now this is a typical scoliosis, but in OI you get atypical scoliosis where there can be one big Cobb and the rest is straight. Very good. So this is an example just to highlight the severity of this problem and how rapidly it can progress. This is a young girl, that cute little girl. This is her X-ray at birth, and you see she had OI type 3, 2011. It's a very slight curve, and we get worried when we see that. Slight curves become big curves very, very quickly. And that was a year later. The curve got a bit bigger. The challenge we have is that if this kid had normal bone with normal fragility, we would have put her in a cast as early as this, but we couldn't cast her because her ribs fracture. The rib fracture by the mom just lifting the baby, so you can't cast her. So it's a really desperate situation, and we just watched it, treated the OI, and this is what happened over 3 years, right? The curve went from that to this curve you're seeing on the right-hand side within 3 years. These X-rays have been seen all around the world at different meetings that I've attended and got multiple consultations. And everybody says, glad it's you and not me looking after this patient, because it was a really desperate situation. Again, this goes down to the genome. Although it was a type 3, it was a severe. The phenotype was extremely severe. A severe type 3 OI. And then eventually I used a technique where we put these hooks at the top and bottom. You graft the bone so that the anchors hold on to the bone before putting the rods in. Otherwise, if you do them both at the same time, it'll just plow out of the bone because the bone is so weak. So this was the consensus we had by showing this around the world, and then we used rods, a single rod with some tapes and hooks. The first attempt, when we went back in, the top hooks were all loose. It had not taken up, even though it was kept for 6 months. So I managed to use the bottom screws, but use tapes at the top. That's something we do as a bailout technique, where we put the tapes around the lamina, because the bone is probably the strongest in the lamina, and that also didn't hold. It lasted for about 6 months, and everything just pulled out because the bone just can't take the force. And then we took everything out, and she was having treatment with teriparatide, experimental drug, PTH, to strengthen the bone. And this is what she is now, like I saw last week in my clinic. And waiting to have some DEXA scans done and start all over again, hoping that the bone is a bit stronger this time. And when we have severe curves like this, we use a technique called traction. So we put a ring around the skull and hang them in traction up to about half the body weight, not for days, for months. They go home in traction, they play in traction, they sleep in traction, and that gradually straightens out the spine. And then you can go back and try to fix it again to stop it from getting worse. So it's a very challenging problem when it happens in the early age and with the severe OIs. This is another sorry, yeah.
Do you ever do non-instrumental fusions anymore? I had a non-instrumental fusion
Yeah.
at 16. It still holds.
Yeah.
My scoliosis didn't get worse, and so I never had to deal with the rods and the hooks and all that kind of stuff.
Yeah.
And I just don't understand why they don't do that.
If the curve is not severe and
Severe.
right. It's a technique that's been used in the past. We don't tend to use it that much because we have the instrumentation that can be used to get a better correction and reduce the risk of non-union. So the problem with the non-instrumented fusion is that the non-union rate is very high. So you've been lucky, it has healed. But the non-union rate is less than 50%. The union rate is less than 50%.
Because they just did they used my own bone
Yeah.
from my hip.
Yeah.
Just pasted it in.
Yeah, and put it in a plaster.
Yep.
Yeah.
And I was in a plaster
Yep.
for 7 months.
Yep.
I mean, nowadays there would be, different kinds of plastic splints or whatever
Sure.
they could have used instead of plaster.
Yeah.
This was in the 70s.
Yes.
But I was supposed to be in it for a year, and at 7 months,
Yeah.
they went in, they took it off, they X-rayed me, and sent me home. It's like, you don't need it again.
Sure.
You don't need another cast.
No, absolutely. So the non-instrumented fusions do work, not in everybody. So sometimes they will go into non-union and the bone doesn't heal. So the bone heals better if you have stability, and the stability is with the instrumentation. In the 70s, the instrumentation was very primitive. So the instrumentation caused more problems than the cast, because they had Harrington rods, as you know, and Lukey wires. But these days we have pedicle screws and more refined instrumentation. So doing surgery with instrumentation, although they can also fail, is we think is better, and it's done more commonly. But there can be desperate situations where we can't instrument, we put to inside to bone graft. Yes.
Just a similar note, I know you had 30 years ago, I think, the chicken wire.
Yes.
Which is quite old. Now there seems a lot of these instruments.
Yeah.
How come the others have not had any problems in that time? So maybe first off, why not sort of the older style? Is there reasoning?
Yeah, so it's very difficult to come to that conclusion with 1 or 2 patients because you don't know the ones that didn't work.
Of course.
So the denominator is unknown. So I think the reason for looking for this newer instrumentation was because we had problems with the non-instrumented and the Lukey wires. And when I was training as a registrar, there was a surgeon that I worked for who used to routinely use Lukey wires in his training. And we had 2 cases every day. One was to remove broken Lukey wires, one was to put in Lukey wires. So it was not benign. And with my generation, my revision rate, I would do 1 revision in a year. But we rarely revise cases these days because instrumentation is better. But don't get me wrong, there are problems with instrumentation as well, and there's always 2 sides to the story. But I think the problems are less, and the success rates are higher, and the power of correction and the rate of union or fusion is much higher with instrumentation. But that's a good thought, right? I mean, and we sometimes when we have no option, we go back to the old technique. Right? We go back 50 years and do what they did 50 years ago. So it's not like we don't use it, but it's rare.
Randolph, could I say in Dr. Gray's defence, the patient he just spoke about with kyphosis, that's the most severe person I have seen in the last 20 years.
So it's, yeah, so
whereas Julia and I were in California at the time where they have a lot of vitamin D.
yes, yes.
Gets through the small.
Yeah, that's right.
So the lesser curves, the smaller curves, we have really no complications, and they do pretty well these days. Out of hospital in a week, up on your feet in the next day, not a cast for 8 months, and you try to keep someone in hospital for 8 months. I'll probably lose my job if I do that too often.
Don't worry.
So, and even the few patients that we have put in prolonged traction, the red tape to get permission to do that is enormous, and for good reason, because we can't have blocking the beds for too long every time. So OI can also affect the old age group with scoliosis. This is an 8-year-old boy who had type 3 OI. Routine skeletal survey, spine looks pretty straight, maybe a very minor curve here. He does have that typical hyperlordosis though at L5S1. Again, that's a combination of microfractures and remodeling, and so it develops that deformity. But reasonably, normal. This is his X-ray that was done at age 14. So 6 years later, and suddenly he's developing a curve. This is a bit like now he's like getting an adolescent idiopathic type curve in an OI kid. So it's not adolescent idiopathic scoliosis, but in that kind of age group. And then it started progressing very rapidly. There's lots of discussions as to when to intervene. As you know, it's a very complex problem. You tell parents you've got to do rods put in your back. No one is excited about it. And then time goes by, the curve gets bigger, and then you reach this point and think, well, we've got to do something now. It's really going out of control. So he obviously had all the medical treatment for it, and then we used these rods, and it was really difficult anatomy getting. So this is one. So we still do the inside to fusion bit. We put bone graft, but we hold the spine with the rods so that we don't have to put them in a cast. And it's been one of the most difficult cases in terms of getting these iliac screws in, because his pelvis was so thin. I couldn't get any decent fixation. And as expected, one of the screws at the back pulled out. He was still fairly asymptomatic and very happy, but it had to be revised. And these days, the reason I'm showing this is that we have amazing technology in our health system, where we can use computer navigation, we can use intraoperative CTs, various things to place these screws way more accurately and better, and have a good outcome. So the surgical treatment side has improved tremendously, even over 10 years, to the point where nothing is impossible. Everything can be done. It just takes a little bit more planning and effort. So that's for scoliosis. Any questions on scoliosis? Yes?
Not so much about scoliosis, but I'm reminded of somebody once said that for every complicated question there's a simple answer, which is inevitably wrong. So having said that, I know people who improve their scoliosis not with OI, but with other disabilities or with other just simple back problems.
Yeah.
By hanging upside down.
Yeah.
It's by creating some tension this way.
Yeah.
Can you make any comments about the kinds of things, ordinary physical things that can be done to address that before you go to the surgery?
Yeah, so it's a good question. It depends on what the problem is. So if you're talking about back pain with no deformity, traction works, because you take the pressure off the pain generator, which is usually the disc and the joints at the back. And again, if you go back a few decades, that's what happened when you came into hospital with back pain. You get put in traction, and you're left in traction for a couple of weeks, and your pain gets better. You can't do that these days. But the inversion table, which you're referring to, is another way of putting traction and distracting things using the weight of your body, where you strap yourself with the ankles and.
They just hung upside down in the doorway, to be honest with you. They did it on like 3 or 4 times a day. Sounds a bit autism.
Yeah.
I wouldn't necessarily recommend that.
And I'm not that.
Not for Lorelei.
So traction generally works. It's how you do the traction is debatable. The physiotherapist used to have a lot of inversion tables, but again, all you need is a couple of accidents, and then lawyers get involved, and the whole thing goes south. So, but some people have inversion tables in their house, in their home. They go and strap their ankles and tilt the table, and the gravity does the traction. And it works because it takes away the pressure of the pain generators in the back. Right?
Just similar to that question, some people have recommended a sleep system, which is almost like certain pillows that have a framework.
Sure, to support the back better.
Yeah. Improve scoliosis. Do you think that sort of thing works?
Well,
some of it is cushions, but it's
Yeah.
built on like steel base.
I mean, I guess it's similar to a brace. So the way the brace works is that if you have a curve going to the left, you have one point at the apex pushing the curve in, and two other points on the opposite side pushing the spine the other way. So it's a 3-point kind of push, and I guess you could set that up while you're sleeping with various cushions. Or so I wouldn't be surprised if it works. And over time, the spine can remodel. Especially in the growing spine. Not so much in the adult spine, but in the growing spine, it can remodel. Yeah,
So that was an important question.
Yeah.
Do we still use the standard bracing programs for
Yes.
idiopathic curves?
Oh yes, it's the mainstay of treatment.
And then just tell them, if you could explain the structure. So you actually have a nurse practitioner as well
Yeah.
as part of your team.
Yeah.
And the children, the young adults, like teenagers, are actively managed
Yes,
through their adolescent curve,
correct.
even to the point some need surgery here.
Yeah, so if you come to our clinic, regardless of what the etiology of the scoliosis is, we work out how old you are and how skeletally mature you are, and that's based on your menarchal status, if you're premenarchal or postmenarchal, and it depends on some x-rays we do, especially the x-ray of the hand, and you can tell how much more growth is left, and then we look at the size of the curve. And so typically if you're under 14 and you have a curve that is under 40 degrees, and you are a Risser 0 to 2 or a Sanders 3 or 4 based on the hand x-ray, you would get a brace. You get a brace fairly rapidly. And then you'll wear the brace through your teenage growth years, and then we monitor the curve during those years by doing x-rays every 6 months. And we refer to as failure of bracing if the curve gets beyond 50 degrees in the brace. Then we say, well, the brace has not worked. We've got to now look at what else can be done, which is often surgery or nothing. There's a study published by Dr. Weinstein in the New England Journal of Medicine in 2010, I believe, that for the first time after decades of bracing, there was a proper randomized controlled trial done on bracing, and it showed that it works, and they had to, on ethical grounds, stop the study because the bracing group was doing so well. With the interim analysis, the study had to be stopped, and the number needed to treat to prevent scoliosis from progressing from a non-surgical curve to a surgical curve was only 3.
Wow.
Only 3, so NNT was 3. That's a pretty good, that's amazing, right? So for that reason, they stopped the study. They said it is unethical for us to randomize kids anymore to non-bracing versus bracing. So we brace all our kids if they tick those boxes. Now, if it's OI, it's the same thing, unless, of course, your bone is so fragile that you can't mold a brace, because the brace works on pressure, on molding.
So if you brace all of your kids,
Yep.
if it's required, what
Yeah.
kind of bracing are you using?
It's a Boston type brace.
A Boston brace?
Yeah, a Cheney brace or a Boston brace.
Sorry,
A Cheney brace or a Boston brace. So, I mean, the authorist has their own way of making the brace, but the way they make it is based on 3-point fixation, 3-point push. So it's a Cheney Boston type brace made of thermoplastic. Yeah. Yes.
Just to add to what you're saying, our daughter Olivia sees Dr. Gray at Randwick,
Yeah.
and she's got a double
Curve.
She had a brace put on the 31st of May. Her thoracic was 45, her lumbar was 39. We went back 5 weeks ago, and the brace does work. Her thoracic is 27, and her lumbar has gone down to 19.
How old is he? How old is she?
She's just turned 13.
13. Premenarchal?
Yes.
Yeah, so that's a perfect patient to brace. Huh?
And the brace is, everyone that's seen Olivia probably wouldn't even notice that she's got the brace on.
No,
It is really thin. Now, I think Deb x-rayed her with the brace on and with the brace off, and you can notice a huge difference in just that. And she wears it for 20 hours a day and tolerates it really well. And you can't even tell she's got it on. So for people who are thinking, oh my God, a brace, it's actually, we've got it there to try to correct as much as it could, but we are realistic that she's going to have rods, because I've had rods, and don't be scared of a brace if that's what your doctor's saying, because it does work.
And that's very true. Kids tolerate braces amazingly well. Once they get used to it, the compliance rates are very, very good.
And I think what we were saying earlier is look, these curves in OI, they are contributed to by the idiopathic curves that we see in, on lots of young females. And so we need to be really, I think, aggressive, because we want to prevent them either needing surgery or later on in life having scoliosis that are complicated by vertebral crust fractures, the OI pathology versus the idiopathic.
I think you got to jump on it very early. You got to get, as soon as you see a curve that's more than about 20 degrees, you got to go and keep bugging your doctor, do something, get a brace, see what can you do. Don't wait until it's 40, because then it's much harder than when it was 20.
Just to add to that, hers last year was under 20, and she had a growth spurt.
Yep.
In that 6 months that he said, come back and see us, because she'd had a big complicated leg fracture. It had progressed, so it was like, today you're going down to get it. So it's not always, we thought in our head it was less than 20.
But it rapidly, it's
review,
double
and
the
there was
size.
a rapid.
Yeah. So radiation is always a concern with these repeated x-rays that we do on kids, because there's a cumulative effect of radiation. So we're lucky these days we have what we call the EOS scanner. We've got about 5 scanners around in Sydney, and they deliver a radiation dose that's 1/20th that of a normal x-ray. So we can do EOS scans more frequently without exposing the kids to unnecessary radiation. In fact, the ultra low dose EOS scan is equivalent to 2 weeks of cosmic radiation. So it's that low. Because that was the other concern that we all had, are we x-raying these kids too often? Every 4 months, there's a lot of, that's 3 x-rays. And a standard x-ray is equivalent to the cosmic radiation of 1 year. So therefore now we can x-ray them more frequently, so we don't run into that kind of problem. Yeah. Yep.
Do you do much work with adults with scoliosis?
Yes. Yes.
The incidence of the scoliosis getting worse through menopause, have you had experience with that?
Yeah. So yes, so the average increase in the curve, I'm talking about non-OI patients here, is about 0.5 to 1 degree a year through the young adult life. And what actually happens, why patients run into trouble, is that especially with the lumbar curve, with age you get degenerative changes, and at the apex of the curve in the lumbar spine roughly between L3 and L4, which is where it always occurs, the vertebrae starts slipping sideways, called lateral listhesis, and that is an extremely painful condition. So the curve gets bigger up to some point, and then because of the arthritis, the spine kind of locks in and it doesn't continue to get bigger, but the listhesis happens as a secondary phenomenon. And that's what gives the pain and results in adults having spinal surgery because the pain becomes intractable. And of course, then you also get the nerve pain, the leg pain, the radiculopathy, the sciatica type pains that we refer to as.
Have you done surgery on adults?
Yes, that's 50% of my work. Yeah, so the adults, So the reason why that occurs is that sometimes, so we don't surgically treat kids' curves if they are definitely under 30 degrees or less, or sometimes even 40 degrees. We don't think it's beneficial to put rods in because rods also cause problems down the line, and therefore we leave them alone. So those patients can sometimes run into trouble as adults in the 3rd and 4th and 5th decade years. So there is a fair degree of not a large, but a significant population that go through the pediatric age group, not necessarily needing to have surgery, but run into problems later on because it's a progressive condition. So spondylolysis in other words, a pars fracture. You see there's a line here, and those two bones should be connected. So the pars is the bit of bone that joins the superior facet to the inferior facet. And when that fractures, we call it a spondylolysis. Now, this diagram again is to show that's the pars on the far left-hand corner on your screen. You can then get a spondylolysis, which is a fracture, and then it can slip forwards because you don't have that connection, and the disc starts wearing out, and the glue that's holding the two vertebrae together starts becoming weak. Now, in the non-OI population, we generally see this phenomenon happen in the 3rd and the 4th decade because until such time, this disc holds the vertebrae together. So what triggers the spondylolisthesis is a degeneration of the L5-S1 disc. The spondylolysis is mostly asymptomatic. They might have some non-specific back pain, but it is often an incidental finding. Even the spondylolisthesis in the young adult could be an incidental finding, where you do an X-ray for something else, and you see, oh, hang on, there's something wrong here, and then you realize that you had a spondylolysis all your life, and now it has started slipping. We grade the spondylolisthesis as using the Myerding grading as 5 grades. The grade 1 is when there's a slip that is less than 25% of the width of the vertebrae. Grade 2 is when there's up to 50%, 3 is 75%, 4 is 100%, and 5 is when it goes off the top. This is called a spondyloptosis. So there's a complete dislocation of L5 on S1. Extremely rare to see. The most common ones are either a 1 or a 2. So when it becomes a 4 and a 5, or even a 3, we call it a high-grade spondylolisthesis, and if it's 1 or 2, we call it a low-grade spondylolisthesis. So this is a rough grading of the spondylolisthesis that occurs as a result of this spondylolysis, which is a pars defect. So as I said, it's mostly asymptomatic, incidental finding on X-rays. They can present with back pain. So if a teenager comes to us with back pain, who is usually active and sporty and doing a lot of extension type sports, the first diagnosis is a spondylolysis or a stress fracture. So we do an X-ray. Not all spondylolyses are obvious on an X-ray because you can have a stress fracture that you don't see on an X-ray, but that is hot on a bone scan or shows some increased signal on an MRI scan. So we do this special oblique view. It's called a Scotty dog. Can you guys see a dog here? That's the dog, right? That's his ears up there, and that's the neck, and then that's the body, and he's the front forefoot, and that's the hind foot. It's a dog, right? It's a little puppy. It's a little puppy. So the fracture is in the Scotty dog's neck. So you see that's intact, and you look at here, it's fractured, right? So sometimes if you don't see it on the lateral, if you do an oblique view, you can see that the Scotty dog's neck's fractured, and that's a pars defect. And this is in a situation where there is no listhesis; it's only a fracture. So we look at these X-rays to see if it's normal. And they still have back pain. Then you would do a bone scan or MRI scan. They can also present with leg pain. So if you have a spondylolisthesis, especially the nerve root that comes out between these two vertebrae, can get compressed and give you typically L5 radiculopathy down your leg. So when you do your imaging, you find the reason for the radiculopathy is the nerve compression at the opening between L5 and S1. So these are the three. Commonest is asymptomatic, incidental finding, back pain, and leg pain, or both. Is that clear? Right. Now, what's the prevalence? This is the most recent published article about the prevalence of spondylolysis or listhesis in the OI population. And if you look at the spondylolysis, it's about 8.2%, and the average age was about 7.5 years. And the spondylolisthesis was about 10.9%, giving a combined incidence of about 19.2%. Now, the previously reported incidence was actually pretty low, and that's because the studies were not good. It's not because it was low. They didn't have good studies. But this study was fairly recent and fairly robust, and it showed that the incidence is actually much higher than we think, because it was low because we didn't look for it. We didn't look for it, it's actually there. And if you look at the spondylolisthesis group, there are two main types. You can have the dysplastic and the isthmic. Now, a dysplastic spondy is when the pars fractures and heals. It fractures again and heals. And this happened multiple times, and as a result, you find an elongated pars. So there's no actual fracture, but there's an elongation of the pars, which still gives you that listhesis, but not actual fracture. And the other group, which is 75%, you can actually see a defect, and it leaves the posterior elements behind, and the front goes forwards. Prof. Selen sent me this study that was done at the Kids Hospital and University of Sydney, Prof? Yeah, Verity, yeah. So this is very interesting because I had not seen this. It is still unpublished, but the incidence in this group was actually significantly higher. It was actually 42%. The prevalence of spondylolisthesis was 42%. That's more than double what was previously reported. So maybe this does exist a lot and we just don't know about it because we're not looking for it. And if you look at the types again, type 1 had a prevalence of 32%, type 4 50%, and type 3 91%. And type 3 obviously being the more severe OI, would we think makes intuitive sense that you're very likely to get a fracture of L5, and for that to slip forwards, either a fracture heal causing a dysplastic or actually true spondylolisthesis. So maybe we should be looking out for this more carefully, because believe me, it's not easy to actually pick a spondylolysis on an X-ray, especially if the X-ray is not done properly. So I suspect most of them go undetected because they're asymptomatic, not that because they don't have it. So the management is essentially conservative. If you have acute back pain as a result of the spondylolysis, you would minimize your activity, especially the extension type activity, treat your symptoms symptomatically and give it time to heal. Rest and symptomatic treatment. Sometimes you can use a brace. It is not your typical brace that you use for scoliosis. It's more a brace immobilizing the lumbosacral junction. So it's a bit lower going down into your bums and not as high going into your axilla. So it's trying to protect the lumbosacral spine as opposed to treating a scoliosis. And you can treat them surgically. Now, I must say I've not been bold enough to treat anyone with OI as pars fracture surgically because we have not had patients who have been that symptomatic, because you're dealing with fragile bones and it could make things worse. Just going back to the instrumentation, if you put your instrumentation is only as strong as the bone you put it into. So if the bone is not strong, you can put the best instrumentation in the world, it's not going to work. So the two main types is you can do a pars repair, where you're primarily trying to repair the pars defect, either through a pars screw or that kind of a construct at the top. Or if it is very severe and there's a big spondylolisthesis, you can do L5-S1 fusion. Now, this is not an OI patient, but this is an example of what we would do with the L5-S1 fusion, which is doing pedicle screws in 5 and 1, and then interbody cage to get the 5 and 1 to fuse. So therefore, having a pars defect is not an issue because you have fused 5 down onto 1. So this is the next big problem. How are we for time? Okay, so I'll go quickly through this. Craniocervical junction abnormalities are a very difficult problem to manage. It's a significant issue, and we've got to look out for it very early, because the sooner you diagnose it, the easier it is to manage. It's much harder to manage severe basilar invagination than to manage early basilar invagination. The incidents are around 37% in the overall group of OI patients. Bacillar invagination is about 13%. Bacillar impression, that is the early form, is 15%, and platybasia is about 29%. And you do some baseline cervical, or it is recommended that you have baseline cervical and base of skull X-rays prior to the age of 6, just to pick the non-clinical craniocervical junction problems.
I just have a quick question about
Sure.
that. Is it common for the subluxation of the C2 and C3 in OI patients?
It's common to have subaxial subluxation as well. Yes, yes. So you could have craniocervical problems and subaxial problems, but the ones that can be lethal are the craniocervical issues, where if you have a severe bacillar invagination, it impedes, it can compress the spinal cord at the level of the foramen magnum and even the brainstem, and then cause respiratory issues. Right?
So if there's a fracture there,
Yeah.
is it just as long as the spinal cord's intact and that's safe, and then
Well, with what type of fracture, like a C2 fracture?
C2?
Yeah, so if it's a type 3 or a type 2 C2 fracture, you would immobilize the neck or the craniocervical junction and let it heal. Yeah. So this is when the skull starts subsiding into the cervical spine. The C2, the dent, starts migrating through the foramen magnum. And the foramen magnum is exclusively for the spinal cord. Nothing else should be in there, right? So it doesn't have room to share it with anyone else. So if the odontoid process then starts migrating upward, that causes a lot of problems. And the primary treatment is to first put you in traction and pull it out, and then fuse it so that it doesn't subside again. So in summary, spine is a commonly affected part of your body with OI. You should look out for problems and pick it up early. The earlier you pick it up, the easier it is to treat, and you can avoid the severe deformities and severe problems. So we recommend that everybody has a spinal screening radiograph by the age of 6, and that includes the craniocervical junction. Clinical examination and neurological examination is mandatory. You do the Adams-Sword bending test. Doesn't matter whether you think you have a scoliosis or not. It should be fairly routine, and we do that at the kids' hospital. And we don't even do that. The endocrine team, they know how to do all those examinations. They send the patients to us if they're concerned. And then a spinal radiograph as a baseline so that you have something to monitor. And that should include, as I said, a lateral C-spine and base of skull X-ray, very important. And early bisphosphonate or biphosphonate treatment reduces the progression of spinal deformity, and that's been shown by some cross-sectional studies, and improves your bone quality so that if you do come to have surgery for a progressive scoliosis, you have better bone stock to do your instrumentation. So I think we'll stop there and take any further questions here.
I had a spinal X-ray to do with my QCT earlier in the year. Now, what's the normal procedure when you have an X-ray for your spine? You breathe in, don't you? Whatever it was, the young technician said do the opposite, which I think is breathe out. And what it did, it got the lungs out of the way so that you actually saw more of the spine. So is that something that we should be saying to the technicians? Do it the way that you don't normally do it so you can see the spine better?
With the X-ray technology we have now, you don't have to do that.
Which is interesting that she did that.
We get good, but she's right. If you fill up the lung with air and make it less dense, you'll see the spine better. But that we only do that occasionally when you can't get a good X-ray.
Yeah, well, you can't with my bones because I've got scoliosis, and I'm a past. I always tilt because I know I've got it, but I'm too old, and no one ever mentioned it years ago. But I just thought I'd mention it, and I just thought it might be something interesting to say.
No, it's
with the kids that are severe, if you want a better X-ray of the spine, do the opposite to what you're meant to do.
It's a good point.
Thank you for
no problem.
an informative presentation.
Thank you.
I have grade 1 spondylolisthesis.
Yep.
One of the discoveries when that all came to pass was dural-ectasia, and I
Yep.
just wanted to know if you had any thoughts on that aspect of
The dural-ectasia?
Yeah, because everyone I've spoken to
Yep.
doesn't know whether to think that it's protective, contributive. We don't know in terms of managing the hopefully prevention of the progression
So-
beyond grade 1 that we're trying to manage right now.
The dural ectasia is a problem only if you come to the point where you need to have surgery.
Okay.
Because what happens with dural ectasia is that your pedicles become smaller.
Right.
Because the dura is expanded, the pedicles are small, and the pedicles are your key fixation points. So therefore, it affects the actual surgery, makes the surgery technically more difficult, and makes the fixation a little bit weaker. So you might have to use different techniques, like going through the front as opposed to the back. But that's where it is mostly relevant.
Okay.
I don't think.
Otherwise, for conservative, non-surgical management,
Yeah.
it's not a
It doesn't
path.
change the management, the algorithm.
Thank you. I'll pass it on. Thank you.
Yep.
When you say like early identification screening by 6, is that something you would go to your GP and say, can you do some testing, or do by 6 we need to have a spinal surgeon?
Someone who is conversant with OI patients should screen. So if your GP knows what the problems to look out for, if you just walk into a GP practice and say, can you screen me for OI related problems?
So I am from the Randolph coast. We don't come down to the Sydney clinic.
Yeah.
So I don't have a team as such. We're just
Right.
managed by our
Right.
pediatrician.
Usually the physiotherapists are a good port of call. They know a lot about spine and spinal issues. I would think the physiotherapist or the GP would be the first point of call. Yep. Yes, ma'am.
What do you think about a theory of the prevalence of spondylolisthesis in young children who've been bisphosphonate treated
Yeah.
from an early age, particularly the children who probably would not have been independent walkers without bisphosphonates, and the fact that now bisphosphonates acts on their bones but it doesn't act on the rest of their connective tissue. Their muscles and joints, ligaments and bits and pieces are unchanged, but now they're running and jumping and skipping and dancing and sometimes getting on a trampoline and jumping on things that they shouldn't when nobody's watching.
Yeah.
And
Yeah.
you know, how do you think that perhaps that has something to do with the ways and
Yes, I mean you could postulate that bisphosphonates, we know it makes the bone brittle. So therefore they can be actually more prone to fractures because they are brittle, and there are few things that people talk about with spondylolysis. One is a pelvic incidence that I said. So if you have a high pelvic incidence, you have a higher risk of getting a pars fracture because the shear forces are more vertical. The other theory as to how a spondylolysis occurs is called a nutcracker theory. That is, with extension, you compress the pars and crack it, right? And the shear forces, which is linked to the pelvic incidence. So it is quite possible that these kids are active. They have got gravity working through their lumbosacral junction. They're jumping, they're somersaulting, they're doing all these things, and their bone is brittle. So that could be why we're seeing a high incidence with our population here, because we have a much better program to treat them medically and keep them active on their feet, but it might be causing a high incidence of spondylolysis. Yeah. But that's something we'll have to look into, I guess. That's been preliminarily done, and I was surprised when I saw that paper. That was double what's being published. So that's there has to be a reason for that.
I think we might wrap it up now, because I think we've had a pretty long day for everyone and we've got more to come. But thank you very, very much.
Thank you for having me. Thank you.